Welcome everyone to the Orlando GI Journal Club. This is December 3rd, 2025, 7 a.m. Eastern Standard Time. Good morning and welcome to all. Our first study is a study from our group looking at the clinical validation of a novel artificial intelligence system for real-time detection of solid pancreatic masses during EUS. The 5-year overall survival in pancreatic cancer is only 11% after diagnosis. However, patients with resectable stage 1A pancreatic cancer have a 5-year survival of 84%. Therefore, outcomes can be improved through early detection. Endoscopic ultrasound is a critical modality for imaging, staging, and diagnosing pancreatic cancer, especially for small mass lesions less than 10 millimeters in size. However, clinical outcomes of EUS and EUS-guided tissue acquisition are incumbent on operator experience and more reliable methods to standardize detection of solid mass lesions is needed. We have therefore developed a deep learning algorithm based on convolutional neural networks for detection of solid mass lesions at EUS. The CNN model included over 32,000 linear array EUS frames of normal solid and cystic lesions more than 10 millimeters in size from 202 patients. The system was developed by trimming the videos and then annotating the videos on software and then verifying and refining the images, which are then reintroduced into the training dataset, enabling the AI model to improve its marking and labeling accuracy and performance. The aim of this study was to validate the performance of the AI-EUS system, which we've named PancreaEUAS, for detection of solid mass lesions. This was a prospective study conducted at a single tertiary referral center here at Digestive Health Institute in Orlando Health. We included all patients 18 years or older with suspected pancreatic lesions due to clinical symptoms, radiological or laboratory findings, and those at high risk for pancreatic cancer based on genetic or familial risk factors. Patients were excluded if they were unable to undergo anesthesia, had a history of gastric surgery, pregnant patients, those with large amount of gastric contents, and those unable to complete an EUS examination. All EUS procedures were performed using the Arietta processor and the Pentax echo endoscope. 2 experienced endoscopists participated in each procedure. The EUS images were displayed on 2 separate monitors placed 3 meters apart, and the endoscopist performing the EUS examination was able to view the conventional EUS, and the second endoscopist was able to visualize only the AI monitor. The primary outcome measure was the detection of solid mass lesions by AI-EUS. The secondary outcome measure was the detection of cystic lesions and identification of normal pancreas by AI-EUS. A total of 308 patients were enrolled. 105 patients had solid mass lesions, 104 patients had cystic lesions, and 99 patients had a normal pancreas. The mean age was 66 years, and there were 53% female and 47% male patients. And 3/4 of our patients were Caucasian. When looking at the detection rate, taking the conventional EUS as the gold standard, there was no significant difference between AI-EUS and conventional EUS for detection of the presence of a lesion. And there was also no significant difference between conventional EUS and AI-EUS for detection of solid mass lesions, regardless of the size of lesion. However, conventional EUS was superior to AI EUS with a detection rate of only 92.3% for AI EUS for cystic lesions, and this was predominantly due to the detection rate of 78% for AI EUS for cyst sizes that were 15 millimeters or smaller in size. When looking at the operating characteristics of pancreatic mass lesions, again, there was no significant difference between conventional EUS and AI EUS for diagnostic. For accuracy of detecting pancreatic mass lesions, and this was the case for mass lesions of all sizes. Looking at the operating characteristics of pancreatic cyst lesions, when looking at pancreatic cyst lesions of all sizes, there was a significant difference between conventional EUS and AI EUS in terms of sensitivity, negative predictive value, and diagnostic accuracy, with the sensitivity, negative predictive value, and accuracy significantly lower for AI EUS compared to conventional EUS. And this was because of significantly lower sensitivity, negative predictive value, and accuracy of AI EUS compared to conventional EUS for small pancreatic cysts 15 millimeters or less in size. For pancreatic cyst lesions 16 to 29 millimeters and those greater than 3 centimeters, there was no significant difference in the operating characteristics between AI EUS and conventional EUS. The limitation of this study is that we did not include any clinical data within the AI model, which can potentially further enhance its performance and improve clinical workflows. This also was a single-center study, therefore there is limited generalizability and requires external validation. Training data and validation undertaken using a single EOS processor in the study. Therefore, the performance of Pancreas EOS with other EOS processors is unclear and requires further testing. The study was focused only on the detection of solid mass lesions and not on the characterization of lesions. Additional software developments are therefore required for lesional characterization and correlation with tissue diagnosis. So, data from our study demonstrate that performance of AI EOS was comparable to that of experienced endosonographers for detection of solid pancreatic mass lesions. By standardizing performance, AI EOS may have the potential to optimize performance and standardize clinical outcomes in pancreatic cancer. Thank you. Okay. Our next study is a meta-analysis of randomized trials looking at cold snare polypectomy versus hot endoscopic mucosal resection for large non-pedunculated colorectal polyps. And this is by Sorge et al., published in Endoscopy. Hot EMR is the standard of care treatment for large non-pedunculated colorectal polyps. However, use of electrocautery is associated with risk of complications that include post-polypectomy syndrome, perforation, and delayed bleeding. Cold snare polypectomy is preferable to hot snare EMR for adenomas that are small, less than 10 millimeters, and cyst-ulcerated lesions, and the current guidelines recommend cold snare polypectomy for non-dysplastic cyst-ulcerated lesions, regardless of size. However, there are concerns regarding the use of cold snare polypectomy for large non-pedunculated colorectal polyps due to the higher recurrence rate. And use of cold snare technique can be challenging in polyps with sessile components or those with fibrosis, for example, from prior biopsies. The authors therefore performed a meta-analysis of randomized trials to clarify the impact of cold snare polypectomy on the risk of recurrence for resection of adenomatous and serrated large non-pedunculated colorectal polyps larger than 15 millimeters in size. A total of 4 randomized trials were included in this meta-analysis comprising 1,516 large non-pedunculated colon polyps in 1,442 patients. These are the characteristics of the four randomized trials included. They were all multicenter randomized trials except one by O'Sullivan et al. The largest randomized trial is from Paul et al., comprising 336 cold snare and 324 hot snare patients. In terms of the size of the polyps, they were around 3 centimeters in size, except for this study by Nogales et al., where the polyps were a little bit smaller, where the median polyp size was 25 millimeters compared to mean of 30 millimeters. In terms of the location, the majority of the polyps were in the right colon, and the studies comprised a mixture of adenopatous polyps and cell-ulcerated lesions. In terms of margin ablation, this was performed in all patients in the hot snare AMR in the O'Sullivan study, but only in about 30% of patients in the study by Stanbrook in the hot snare group, and then 80% in the Pole study. Clip closure was performed in a wide variety of patients in the study, only 9% in the Pole study, 43% in the O'Sullivan study. The follow-up duration, on average, was a median of 6 months, and a little bit shorter in the study by Stanbrook et al. At 4.3 months. The primary outcome was to look at the recurrence rate. So in this meta-analysis, when looking at the recurrence, cold snare EMR had high recurrence rate at the first surveillance colonoscopy compared to hot snare EMR, with recurrence rate of 22.6% in cold snare versus 10.8% in the hot snare group, with p-value of 0.02. However, when looking at the adverse event of delayed bleeding, there was a significant lower risk or lower rate of delayed bleeding in the cold snare group, with pooled rate of 1.2% in cold snare versus 3.9% in the hot snare group, with p-value of 0.03. The limitation in this study was that in this meta-analysis is that they inclusion of full text articles and conference articles / abstracts. And the inclusion of conference abstracts, although it does increase the number of patients included in the meta-analysis, do need to be interpreted with caution. There was also moderate to substantial heterogeneity across studies for intraprocedural bleeding, especially as intraprocedural bleeding. And also, if you look at the initial table of the included studies, there was a wide variation actually in the use of clip placement after hot snare EMR, which will affect the rate of post-procedural bleeding. And so that also needs to be interpreted with caution. Also, all the randomized trials were conducted in expert centers, which limit the generalizability of the study outcomes. The take-home point from this study from this meta-analysis is that cold snare EMR nearly doubled the recurrence risk of hot snare EMR for large non-pedunculated colorectal polyps, but it does have a superior safety profile, and therefore it may be a preferable option for patients when procedural safety is prioritized over minimizing the risk of recurrence, for example, in patients with extensive comorbidities. Okay, so for general recap, the data from our study demonstrate that the performance of AI-EOS was comparable to that of experienced endosonographers for detection of solid mass lesions by standardizing performance AI EOS may have the potential to optimize performance and standardize clinical outcomes in pancreatic cancer. Cold-Stent EMR nearly doubled the recurrence of hot-stent EMR for large non-pedunculated colorectal polyps. However, its superior safety profile may make it a preferable option for patients where procedural safety is prioritized over recurrence risk, for example, in patients with extensive comorbidities. Our next journal club will be on January 7th, 2026. Thank you so much for joining us this morning. Please have a wonderful day, week, and month. Happy holidays to all. Happy New Year. Thank you so much for being with us over the last 12 months, and hope to see you for the next 12 months to come. Thank you so much. Take care. Bye.